Thank you, Mr. Speaker. To the bill.
Bill.
Thank you. I wanted to say a few words about the original bill, the base bill, and then also a few words about the amendment. We got three different organizations, national organizations, writing in about this bill. Families USA is an independent healthcare-oriented organization, very much in support, been working around the country. I want to read a few words from Consumer Union, the Policy and Mobilization Division of the nonprofit Consumer Reports, which has a national campaign to end these surprise bills. Over the past 2 years, 6 states have enacted such consumer protection, and this year at least a half a dozen more have introduced bills. I could go on and on about the survey they found and how often this happens and what the average cost is, about $38,000 for people who end up in the ER with these kinds of bills. But I'm going to skip to something at the end here. Consumers should not pay the price for the complicated contracting relationships among doctors, facilities, and health plans. Consumers with insurance should be able to go to an in-network facility and have the confidence that their health insurance, for which they pay hefty premiums, will cover their care. HB 2339 would ensure this protection by providing that consumers who get care at a participating facility will be responsible only for the in-network co-pays, co-insurance, and deductibles. Now, in terms of the amendment and how the reimbursement gets pegged, it says, as introduced, this bill also establishes a reimbursement rate for non-participating physicians in this situation as the, quote, reasonable and customary rate, basing reimbursements on billed charges for which there is no outside limit, creates inflated health system costs which would be passed along to consumers in premiums. That is the reason that we went away from that. It also, using billed charges as the basis, would not create any incentive for physicians to join plan networks. We understand the committee is considering an amendment that would rely instead on a percentage of the Medicare rate, a better approach Consumers Union supports, since that is based on a publicly available vetted standard. So we talked in the committee about a lot of different standards. I felt comfortable with pegging it at this rate. The original rate that I heard in terms of using Medicare as a standard was $175. Then it went up because we were really trying to consider, I didn't see it as a partisan thing. I think that the two people that were really speaking in our committee about this have a provider, understandably, a provider hat on and understand what this could be to providers if you set the rate too low. And certainly that's a concern. If the rate is too low in rural areas in particular where they're going out, they're not in network, that could be a problem. And on the other hand, when it's too high, you disincentivize providers from joining an in-network, which is one of the ways that insurance companies, and we try to keep the cost down. So it's hard on insurance companies, hard on the whole system of in-network providers when we set the rate too high, and hard on participating providers when you set the rate too low. So it did bounce around for a little while because there was some genuine trying to find what's the sweet spot there. DCBS and Osberg were at a work group in which they were trying to find this. It turned out that a lot of the in-network rate for current providers are 200%. We want to make sure that it doesn't go over that, and that's why I believe we landed at 175%. So I encourage your adoption of this bill. Thank you.